Thank you so much. I'm going to talk about EMS, and there's several topics that we're going to cover today. Hold on, let me just make this go. Okay, things are not going. They're not going. Anyway, what I thought I would do is talk to you a little bit about EMS worldwide, and certainly we've all had experience with that. We're seeing expansion of EMS as we go forward. I'm going to talk a little bit about pre-hospital readiness and some of the activities that are going on in the United States relative to pre-hospital care of children and how to make our EMS systems more ready to care for children. Let me see if I can. Could you let them know, Manoj, that it's not advancing? Anyway, I'm just going to keep talking because I know the subject matter, but we'll see as we go forward. There are several things. First of all, globally, there's challenges in terms of EMS systems. They haven't been necessarily. Here we go. Okay. Thank you so much. Thank you. This is not working. Oh, there it goes now. All right, as I mentioned, the EMS systems globally are really in its infancy. Many countries in the world are still trying to develop EMS systems. First of all, we see the emergency department is underdeveloped in many countries, and then we also see that EMS. I was going to talk to you also about EMS 2050, which is a vision for EMS going forward into 2050, and what might EMS look like. And I think some of this translates to emergency medicine, but I think it's helpful. I'll mention briefly the National Pediatric Readiness Project, which is something I've been involved with for many years, as well as pre-hospital readiness to care for children. So as I mentioned, EMS is really in its infancy in terms of its development on a world stage. Only about 50% of countries really do have EMS systems. And most systems favor BLS, and we do know that, or BLS plus, meaning BLS plus additional skills. And we do know that BLS is actually quite effective and maybe even better in some instances than ALS, although we know that there's some ALS skills that improve outcomes. Things like giving albuterol in the field. We heard Dr. Shaw talk about steroid use in the field, CPAP for adults as an example, and certainly treatment of hypoglycemia has been quite useful as ALS skills. So what are the factors that impact what we do in the out-of-hospital setting? First of all, the medical resources and training, and that is going to make a difference in terms of what kind of protocols. Funding sources, and funding can be quite a difficult issue when you talk about pre-hospital care. And then the other issue will be cultural competency to care for patients of various backgrounds. On an international level, there's a number of different systems. Some call it, the Franco system or Franco-Germanic system, which is more in line with having physicians on board. When we think about the American system, which was really brought up with the idea that we'd have pre-hospital providers that are trained EMTs and ultimately paramedics. And that was developed from a medic or corpsman that occurred in the war theater, and they came back to the United States. And we realized that actually there were more deaths on our highway that occurred in the war theater. And we said, why is that? And the reason is that we didn't have rapid identification of injury and then transport to a center that could take care of them. So the different models are, you can see ALS, BLS first responder, lay provider, or physician. And some of the countries, you can see Saudi Arabia, also with Red Crescent, I believe, has, my understanding, has physicians riding along. But there's some, like the King Faisal system that you have, has actual paramedics, which I think is really interesting. As I mentioned, the World Health Organization says half the world countries have no EMS system. So what do? You throw them in a vehicle and you somehow get them to a hospital. And when I was young, there was no 911. The first 911 call in the United States occurred in 1967. And what happened is I remember my sister put her leg through a glass window and cut her leg severely. It was bleeding, and my father wrapped it and threw her in the front seat and then drove as fast as he could. He was stopped by police because he was driving so fast. And my father said, "She's bleeding." And the policeman almost passed out when he saw the injury, and then said, "Follow me," and escorted my father and my sister to the hospital, where she had almost 200 stitches in her leg, but did well. Anyway, again, developing countries' organized systems are hindered by any of a number of things, and it may be poor infrastructure. And we do see that on a rural stage. Here we see nice highways, and in the US, you see pretty nice highways, but the issue is some of the infrastructure is not there to warrant vehicles traveling and picking patients up. And EMS for children is even more in its infancy. You can imagine on a rural stage that if you don't have training enough or you don't have the infrastructure, you're certainly not going to have it to take care of children. So there's really a lot to do. And this is just a review that goes over some of these issues from a global perspective. What we do know is adding at least BLS care and some kind of transport makes a difference, and that has been identified in Canada as well as Mexico. And there was a large trial in the United States, the OPALS trial, which actually showed that BLS care was very important and possibly superior to ALS care in terms of taking care of patients in most instances. The difference was for cardiopulmonary arrest, the ability to do rapid defibrillation was really critical, at least for adults. For children, as we know that VFib arrest in children, the likelihood of that is relatively low compared to asystolic or PEA arrest. Now I'd like to just bring up, I mentioned earlier the Pediatric Readiness Project. And we have two types of readiness projects. We have one that's based in the emergency department, and that's the National Pediatric Readiness Project. And the other is a pre-hospital readiness project. And Dr. Shaw and myself have been involved in this effort nationally in the United States to begin to look at EMS systems and try to encourage them to do those things that are necessary to take good care of children. One thing that I found early in my career is they didn't even have the equipment that was sized appropriately, nor did they have the training to take care of children. So as you know, you take an adult mask and you put it on an infant and you're basically ventilating their forehead, right? I mean, it doesn't do much good. So what we found pretty early on is that we had to develop, first of all, objectives for training. And then we had to have equipment lists of what they might need to care for children of all ages, right? And then we had to reach out on a national level to say, can you mandate this kind of training? And so there's been any of a number of efforts over the last 30 years of my career in order to improve pre-hospital care for children. And what I saw early in my career is literally ambulances would pull up to EDs, to an emergency department, and somebody'd come out and go, we can't take care of sick kids here. You're going to have to drive down the street. And they would divert to another hospital, and eventually the pre-hospital providers would bring them in. And so a lot has been done since then, thank goodness. And so there's been any of a number of national courses developed and to train pre-hospital providers in the care of children. One is the PEP course, or pediatric education for the pre-hospital professional. And that has trained probably about 600,000 pre-hospital professionals really globally. And that would be something to use here to train both ALS and BLS providers. But again, the Pediatric Readiness Project in the pre-hospital setting is designed to try to encourage EMS systems to have certain aspects of readiness that we know from the ED setting that is important in terms of improving the outcome. And one is to have the processes in place, right? And the other is to assign someone the role to address pediatric issues. And what we found in the ED is that if you assign the role of a pediatric emergency care coordinator, that individual is more likely to ensure that the policies are in place and that they have the equipment and they get the training that they need in order to improve outcomes. So again, a shout out to Dr. Shah, my colleague, in really helping lead this effort. So the collaborators are, as you see them here, and as most things that are done that are worthwhile, you don't do them in a silo. You reach out broadly to those who are stakeholders and you get them involved. And indeed, that occurred with both the National Pediatric Readiness Project for emergency departments, as well as in the pre-hospital setting. And some of the domains of the recommendations you can see here: planning, medical oversight, if you're going to give direction in the field, someone who's actually giving that medical direction also needs to have the training. And I already have mentioned equipment education. There are patient safety issues that can be addressed, such as having a process to determine appropriate medications, and that may be through mobile apps. It could be through a length-based resuscitation tape or other methods. Family-centered care is always good in involving families because they can help identify potential safety events. In addition to that, it gives greater satisfaction and likelihood for them to accept care if indeed families are involved. So family-centered care is very important. And finally, as we all know, disaster management and pre-hospital providers were also on the front lines with all the emergency providers in terms of providing care in the disaster. What's great is that you could essentially Google pre-hospital pediatric readiness and there's a toolkit and there's a checklist, and they're actually really cool, and was developed by any of a number of experts in the United States. And this is just getting rolled out. So I think this would be a great time in order to help develop these kind of resources here. So some of the recommendations, I mentioned planning, getting somebody involved who has, understands the care of the pediatric patient in terms of EMS planning, it can be really, really helpful. I can tell you that during the Northridge earthquake, one of the biggest issues when we had a large number of people displaced in Los Angeles, what we found is that nobody thought about water to mix formula or even formula at all, or diapers. And there was a huge number of families that were displaced, and that turned out to be a big issue. So that's just a minor example, but there's other examples as well, such as patient reunification. And I mentioned collaborating with other experts. And the other thing is just to develop treatment guidelines. These are very important. As we know, we've had discussions about evidence-based guidelines here today. And I think that's really critical as well in the pre-hospital setting, as already demonstrated today by Dr. Shah. The other thing was medical oversight, and you want to incorporate those into both indirect, which is your kind of your offline protocols and your quality improvement, as well as your online or direct medical oversight in which paramedics or a provider in the field is calling to get additional direction on what to do. The final thing is, what's the best destination? And I think here that's going to be critical as hospitals have various resources. You certainly would want to deliver a patient to the appropriate hospital, such as you may want to come to King Faisal, especially for medical conditions, or if you're close enough, you may want to go to a trauma center. Some of the other recommendations I mentioned is having specific equipment, and there are national guidelines. And you can see on the right side of your slide is the national guidelines. And this, again, was a multidisciplinary collaborative to develop what is needed to carry on an ambulance. Because as you know, you don't want to carry a lot of things that you don't use, and you want to make sure that what you use is appropriate and makes a difference. I mentioned education, and I think developing comprehensive and pediatric specific education, but for the pre-hospital environment. You don't want to be teaching paramedics about doing thoracotomies, right? You want to teach paramedics about what they can do in the field that can make a difference, like positioning the head, opening the airway, begin back mask ventilation, checking for a pulse, doing chest compressions, IV access, IO access, and the appropriate drugs, and how to determine the appropriate dose. I think all of those are really important. One of the things I feel strongly would probably be an underestimation of how I feel about this, but I would say that the fact that we have asked paramedics to calculate under pressure with children of various ages is a travesty. I really do. And I think we have to ensure that you don't have to calculate it. You know this in the ED, you know, 2-year-old comes in, 14 kilos, is seizing, is in status. You have midazolam, it's 5 milligrams per mil. How many mils do you deliver? Anybody know? Of course you don't. Oh yeah, well you might be able to calculate it out, right? But it's nice to have something on hand so you don't have that cognitive load. And we actually evaluated this in the field, just standardizing the formulary and having paramedics not calculate. And we did a mixed methods, and what we found is, and it's very difficult to determine what the reduction in error is, but even with all the limitations that we had a 5% reduction in error. But most importantly, what happened is that the paramedics, when we did qualitative interviews, felt strongly that they felt they could take better care of patients, that they felt empowered to actually work with the family, that they didn't have to worry if they were going to make a mistake, and it actually helped them do a better job. So anyway, I'm off my soapbox now, but it is something we're going to continue to try to improve. The other thing that is a real challenge in the pre-hospital setting is, how do you transport children safely? And this can be a real challenge. I mean, obviously putting them in car seats, but not all children can be placed in car seats. And ambulances aren't really designed to carry pediatric patients. So this is still ongoing. There are some guidelines about the safe transport of children. But again, I think we have limitations in this area. The other thing that I think is really critical for any care of the child is ongoing quality improvement. And the recommendations from this is to include pediatric specific measures that can address issues relative to a potential downstream morbidity and mortality. The other thing is just collecting data, right? What we found that's most challenging for most systems is just understanding how many children they see. And that is a real problem, right? So if you don't collect any data and look for variances in data, there's no way for you to do improvement. So you must collect data. So developing good systems and database systems and being able to develop some of those indicators are critical. Family-centered care, I think it's very important to communicate to families. We all know this from the emergency department. The other thing is, do you speak the same language? Sometimes we don't. In Los Angeles, I don't know how many languages are spoken in Los Angeles. I think it's over 100 languages. I'm not kidding. It's very, very challenging to adequately talk to patients. And so developing strategies for being able to communicate with families, I think, is really critical to really understand what's going on. And then I mentioned family-centered care and involving families in the care of the patient and informing them appropriately. And this is really critical because the reason I say this is that a family, you want the family to accept the care, you want the family not to sign out against medical advice, and you want the family to have trust in the medical system. So all of those are critical. And in terms of disaster management, provisions of care, and I mentioned this briefly with families in terms of disaster management, planning to address the needs of children and separation of children from adults. And this has been absolutely one of the most critical things, are tracking unaccompanied children in any disaster. Now, briefly, I want to move on from pre-hospital pediatric readiness to the EMS agenda of the future. This was an effort that was led by NHTSA and many, many other organizations, as you can see listed here. I was a member of the technical expert panel for this, and this was a federally funded project to say where we are now with pre-hospital care and where do we want to be in 2050. And the idea was to be very visionary. What would we want the vision of EMS in the future? And we wanted it people-centered. We also wanted to try to keep people within their communities, and that can be a real challenge based on resources within those communities, right? You may have to drive to a regional center to care for a patient, but again, that might take a patient out of the community, and it might take an EMS resource out of their area as well, so they won't be able to respond to other calls. So one of the things we felt is that the vision is to have people-centered care, keep them in their communities, but what are the guiding principles that help us get there? We want to be inherently safe and effective, and I've already mentioned that relative to care of children. Integrated and seamless, meaning they need to be integrated within the healthcare system in order to be able to do seamless transitions of care, and also to make sure that there was seamless transfer of information about that patient that could be life-saving. As an example, just allergies to medications could be very important, right? Reliable and prepared, being available 24/7, prepared to handle any emergency. Socially equitable is a real tough nut to crack, but what that means is that for any patient, anywhere, they have access to care, equal access to care, and no matter what the background of that patient is, they're going to get the same care, or they're going to get the most appropriate care for their condition. Sustainable can be a real challenge for EMS, and the reason is because the funding sources are so diverse. And now in the kingdom here, I know probably a lot is government sponsored, which I think is probably a good thing. What we do see is various types of models. Some are responsible, are municipalities. It can be state funded. There can be federal funds for this, but this is a real challenge. Even subscription based can occur. And adaptable, I think this is really key, and innovative. We need to keep stretching the limits. We need to keep leaning in to the problems and trying to solve them. And we also need to be adaptable for any situation that may be changed in not only seasonal changes in terms of weather, but other changes in terms of traffic and other things. And we don't know what the problems are in the future, but we have to begin to anticipate them and plan for them. Physicians will lead, I think, in the future, a collaborative system. I'm sure it's going to involve the integration of technology, but it's also going to involve good communication skills amongst many providers. And I think that is really going to be key in the future. My vision would be that you'd be able to call. I would have all the information about you. I could actually reach out to one of your specialists and direct you to a place or that you would have care locally, or that you would be treated and someone would come to you in your home and take care of you. And that would all be recorded, part of the record, and that could be transferred from provider to provider. So achieving this vision is going to involve a lot of work on a global level. It's a huge lift. If 50% of the countries don't even have organized systems and the infrastructure's in place, we have to start from the ground up. For those who do have the infrastructure, what are the things that you can do? And I think one is to begin to plan, understand the resources, and meaning the hospitals, what kind of potential types of resources that you have available, what kind of training you would like to have, and really start working together to develop systems. And if you do, I ask you to think about children from the beginning and not as an afterthought. So what's going to happen? I think really everybody's involved in this. We have to solve this, be able to help people get and have access to hospitals in order to have emergency care. So it really begins now, and it begins with each of us. And thank you for your time, and I know we'll have questions and answers later. So thanks again.